Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the Saudi Heart Association and the organizing committee for this invitation. And this is a very important webinar. It is on cardiac amyloidosis recognition, burden, and evolving management. And we have two excellent speakers. And the aim of this webinar is just transform ATTR cardiomyopathy from a fatal progressive disease into chronic treatable manageable condition. And we have two speakers, Dr. Ahmed Al-Jaziri. He is the first speaker. He is a consultant and advanced cardiac imaging, King Abdulaziz Cardiac Center, King Abdulaziz Medical City, National Guard Health Affair, Riyadh, Saudi Arabia, and he's an associate professor of cardiac imaging. And his talk will be about the TTR cardiac amyloidosis burden and the challenge of timely diagnosis. The stage is yours, Dr. Rahman.
Okay. Thank you, Professor Shar. Assalamu alaikum jami'an wa rahmatullahi wa barakatuh. I'd like again to extend my thanks to Dr. Jaledan and the Saudi Heart Association, as well as the Heart Failure Working Group for organizing this webinar and allowing me the distinct pleasure of meeting some of good friends. Do you see my slide now?
No.
Okay, let's try. I think it will be there within a second. Any luck now?
Yes, sir.
Perfect. Again, in the next 20 minutes or so, I'm going to talk about the ATTR cardiomyopathy disease burden and the challenges of timely diagnosis. Now, when we think of amyloidosis, we think of a systemic multi-organ extra disease that is characterized by extracellular deposition of amyloid fibrils. It can happen in multiple organs, but the organs that stands out and cause problem in the line of clinical presentation of amyloidosis include, of course, the heart, where most of mortality happen. It can affect the kidney, leading to kidney failure. That can affect the liver as well as the autonomic nervous system. Now, there are at least 30 amyloid proteins known so far. 9 of them can accumulate in the myocardium. 5 of them frequently affect the heart. And the cardiac involvement of amyloidosis is attributed in 98% due to 2 types of amyloidosis fibril. So if we think of cardiac amyloidosis in general, we think of either ATTR amyloidosis, in which there are 2 types, the wild type ATTR cardiomyopathy, in which the heart is affected in 100% of the times, and inherited variant type of ATTR, in which the heart can be affected anywhere between 50 and 75%. The other type of cardiac amyloidosis is the light chain, AL cardiac amyloidosis, and in which the heart is affected in 70% of times when patient is diagnosed with AL. The phenotypes of ATTR cardiomyopathy are diverse, but in the center of it is usually left ventricular hypertrophy, where it probably is the base of the diagnosis of ATTR cardiomyopathy. But the patient can present in a spectrum of diseases, including heart failure with preserved ejection fraction, where the highest yield of ATTR cardiomyopathy diagnosis coming from. The patient can present with only atrial fibrillation, particularly when the heart rate is well controlled without medication. The patient can present either with classical degenerative aortic stenosis, or more frequently paradoxical low flow, low gradient aortic stenosis. It can lead to conduction abnormality with heart block, and in very late stages, it can present with heart failure with reduced ejection fraction. So, in fact, you can get the diagnosis of amyloidosis in any form of diseases that can lead to this spectrum of phenotypes. But on the backbone of the diagnosis, which we should always think of, is increased left ventricular wall thickness and left ventricular hypertrophy that is probably diagnosed more so of imaging rather than electrical abnormalities. Now, why do we care about cardiac amyloidosis? We care about cardiac amyloidosis because we have a lot to lose if we don't treat and diagnose and treat the patient in timely fashion. The time of death from diagnosis of AL cardiac amyloidosis is only 6 months, and 36 months of untreated ATTR amyloidosis patient die within 36 months of diagnosis. So there is a lot to lose in a very short time. Now, we could ask the question, why do we care about it if it is that fatal? Because previously we thought that this disease is rare, but not anymore. If you look at the autopsy data, we are looking about 25%, a quarter of patients with above the age of 80 years have ATTR amyloid deposits within the myocardium. And this is probably will be class B heart failure or stage B heart failure if you apply the ACC-AHA heart failure stages. More than 32%, again, 1/3 of patients above the age of 75 have ATTR amyloidosis when they are diagnosed with HFpEF. But when we look at scintigraphy imaging data, the rate increased significantly. We're looking about 13% of all patients, regardless of age, that are hospitalized with heart failure with preserved ejection fraction actually have a form of ATTR cardiomyopathy. 16% of all patients undergoing aortic valve replacement, and this can go as high as 62% if the patient has paradoxical low flow, low gradient aortic stenosis with normal ejection fraction. And then atrial fibrillation can be seen at up to 60% of ATTR amyloidosis, and it can be one of the earliest findings in patients who are affected with the disease. So all in all, we have a disease that is not uncommon, but rather underdiagnosed. And with the fact that the disease is this prevalent, with that rate of mortality, put a lot of burden on us to diagnose it in a timely fashion in order to start a treatment and hopefully improve the mortality and morbidity of our patients. So the diagnosis is not easy, and there are a lot of challenges. Why is that? Because it has a heterogeneous presentation. As I can show you, it can present in any form of cardiac disease that we commonly see. It has non-specific presentation. A patient may present with heart failure or atrial fibrillation, which we all know that it is very common in old ages. It can mimic many common diseases. Therefore, one has to have very high index of suspicion of the diagnosis of cardiac amyloidosis in order to pursue it and diagnose it. So you are having a disease that can mimic a lot of common diseases, and obviously we learn medicine, common things are common. So we always think of the common presentation that may not entirely explain the patient presentation with the disease. Now, the diagnosis is not easy either. We're looking for patients that come across multiple specialties. We're looking for cardiologists, hematologists, oncologists, nephrologists, and most of these patients will probably work their kind of focused discipline in isolation sometimes, and that's to lead to frequent delay in patients' diagnosis. Interesting enough, cardiologists diagnosed almost 1/5 of the cases, and on average, patients usually see 5 physicians before he can get his final diagnosis. And that usually time takes up to 2 years in diagnosis. And that's probably add to the complexity of the diagnosis of patients with cardiac amyloidosis. So whenever we have a patient that has those presentations that we talk about, 3 diagnostic questions come in mind. First of all, is there cardiac involvement with amyloidosis? The second question, what is the phenotype of cardiac involvement? So what is the disease that has disease presentation that led to the patient coming across your way? And in what stage of cardiac amyloidosis cascade we have seen the patient? And finally, what is the imaging modality of choice to confirm the diagnosis of cardiac involvement with amyloidosis. So the question is what to image. If one wants to image left ventricular hypertrophy, then obviously we can look at ECG, although we know that there is discordance of ECG voltage criteria in cases of cardiac amyloidosis. Echocardiogram and probably cardiac MRI are on top of the list looking at the diagnosis of hypertrophy of the left ventricle. If we're looking at the expansion of extracellular volume, well, because of the deposition of amyloid fibrils, then obviously cardiac MRI is the modality of choice. And if we're looking at amyloid fibrils directly, then we should probably looking at SPECT, or more specifically, PET radiotracer in the diagnosis of cardiac involvement with amyloidosis. Now, the first and most frequently used the modality is usually echocardiography. It will give you the classical pictures of increased left ventricular wall thickness, but not only this, the patient will have increased in the wall thickness of the RV, the atria, as well as the ventricle. We will always have small pericardial effusion, but classically, you will have a spectrum of increased filling pressure that can be as early as only mild diastolic dysfunction to those with severe filling pressure with severe diastolic dysfunction. But what really stands out in terms of echocardiography is the strain analysis with the classical picture of apical sparing, in which the apex of the ventricle will maintain its contractility compared to the base, because as we know from multiple autopsy data that the deposition of amyloid fibrils happen more frequently at the base of the myocardium rather than the apex of the myocardium. Cardiac MRI is very helpful in the evaluation of patients who are not very clear in echocardiography. There are multiple findings in cardiac MRI, include those that we see in echocardiography, being high increased wall thickness, apical sparing, although we can't see it visually. But the most important thing or most important characteristic of MRI is the ability to do tissue characterization, in which we usually have the typical picture of diffuse delayed myocardial enhancement. These are delayed myocardial enhancement images in which a normal myocardium should be dark and abnormal myocardium that relate to fibrosis should be bright. As you can see, MRI cardiac amyloidosis can present in multiple forms. It can produce with diffuse, patchy, delayed enhancement, diffused subendocardial delayed enhancement, where it affects the inner part of the myocardium, or it can be diffuse or can be patchy delayed myocardial enhancement. But one of the most important clinical finding in cardiac MRI, the tech will call you back and I said, well, listen, doctor, I cannot get a normal myocardium. I cannot get any part of the heart that looks normal so that I can say confidently that I got the right imaging time of delayed enhancement. But one has to remember that cardiac MRI do not differentiate between ATTR and AL amyloidosis. Although they say if you have diffuse subendocardial delayed enhancement, this is most likely AL amyloidosis. And if you have diffuse patchy, this is ATTR, but this cannot be used in isolation to identify the phenotype or subtype of cardiac amyloidosis. Now, one has to remember also, whether you're looking for AL or ATTR amyloidosis in cardiac MRI, you are imaging the heart during a spectrum of involvement. The myocardium may be abnormal, partially abnormal with partially fibrosis around the myocardium, or diffuse fibrotic process in later stages. So one diagnosis as a snapshot image may not be enough, particularly in those patients with high suspicion, clinical suspicion of cardiac amyloidosis. We moved from qualitative assessment to quantitative assessment. And in quantitative assessment, we can calculate what percentage of the muscle that we see is actually extracellular space compared to intracellular space. And we can do diffuse subclinical fibrosis with putting a number on it. And in that case, we can differentiate different types of left ventricular hypertrophy, particularly those patients with cardiac amyloidosis, whether it is AL or ATTR, compared to those with Fabry disease, iron overload, or hypertrophic cardiomyopathy, where the distinction becomes very clear. If you have increased extracellular volume with increased native T2 images, then this is in a thick ventricle, then the diagnosis is more likely than not will be cardiac amyloidosis. How can this work overall? We know now from multiple studies that if you use extracellular volume as a sole diagnostic criteria, your diagnostic accuracy significantly increase with definite increase in the area under the curve. The bone avid tracer and the evaluation of amyloidosis has been there since the 1970s, where the first report of use of nuclear scintigraphy was reported in 1976. Later on, the first report about the cardiac amyloidosis was also reported in 1982. But for the longest period of time, it wasn't the favorite diagnosis the diagnostic tool to use, because patient could not differentiate from AL and ATTR and everything lumped together, and obviously people could not figure out when to use the scintigraphy. But since 1916, where the first ASNC, American Society of Nuclear Cardiology, practice point guidelines in terms of using nuclear imaging in the diagnosis of ATTR amyloidosis came out, and we knew the specificity and sensitivity of bone avid tracer, particularly BYP scan, in the diagnosis of amyloidosis came out. A lot of interest has been noticed in the area of non-invasive with bone avid tracers. We usually use BYP scan. We inject the patient at rest. We just ask the patient to come. There is no preparation. The patient will be injected. Then we look at the myocardium uptake, and we need to look at the muscle of the heart, not the blood bowl. And if there is no uptake, we give it a grade 0. If there is an uptake that is listed to the bone, we give it a grade 1. If there is an uptake that is similar to bone, we give it a grade 2. And if there is an uptake that is higher than the bone, we give it grade 3. And the diagnostic accuracy is staggering. If you have grade 2 and 3 BYP uptake and you rule out AL amyloidosis, then your diagnostic accuracy is almost 100%. You have 100% specificity and sensitivity without resorting to invasive endomyocardial biopsy. Now, one has to remember that this test is not always positive. We have false positive finding, and we have false negative. The false positive AL amyloidosis can be seen in 12.8% or 13% or positive BYP can be seen in 12% of cases of AL amyloidosis. Hydroxychloroquine cardiac toxicity can give you a positive BYP scan that is not related to amyloidosis. But the most important thing in the negative, false negative, is that there are certain type of inherited or hereditary type with certain mutation that can give you a negative BYP scan, although the diagnosis is although the BYP is although ATTR is the real diagnosis. So the takeout of this slide: if you have a patient with suspicion of cardiac involvement of amyloidosis, it is ATTR amyloidosis until proven otherwise. And if you're in doubt, you should pursue this further. So why do we need SPECT-CT? We need SPECT-CT because we need to differentiate whether the effect or the uptake that we see is actually in the blood bowl or the myocardium. So that's why we always nowadays combine the BYP scan with CT scan to make sure that the amount of uptake that we see is actually in the myocardium rather than the blood bowl, because most of these patients have heart failure. Now, one thing to remember, if your echo and CMR is strongly positive and your BYB scan is negative, we should do endomyocardial biopsy. You have to exclude monoclonal process, even if the BYB scan is positive, because although we know that BYB scan is very kind of peculiar to ATTR amyloidosis, few cases with cardiac amyloidosis due to AL can have a positive scan. And in equivocal result, again, this could be either AL amyloid or ATTR amyloid that it is in early stage. The future is bright. We're looking at many tracers that are PET tracers. They are under phase 3 trials, and these have much more higher affinity to the diagnosis of amyloidosis because they go directly to the and bind the amyloid fibrils than showing expansion of extracellular volume. There are multiple case reports of cases of ATTR amyloid in which the scan of a BYB was negative, but the PET tracer was positive. We're looking, for example, at the isovimetide, in which there is a 90% sensitivity and 100% specificity in the diagnosis of ATTR amyloidosis. As I said, these are all phase 3 trials. Actually, in last May, Bayer have announced that their PET radiotracer met its specificity and sensitivity endpoints, and hopefully will go through a breakthrough FDA approval, and we will see it soon in the market. So now the question, whom should we screen? If we have all of these findings with those particular group of patients in whom the likelihood of diagnosis is high, should we go ahead and screen every single patient above a certain age or disease or patient that have heart failure? Luckily, we have some guidance in this. And the guidance from multiple guidelines, be it the American, be it the European, be it the echocardiography or imaging modality, they say you need to have a left ventricular wall thickness. Although this is not a must, a lot of patients that have cardiac amyloidosis may not have the cutoff of 12 millimeter, but keep that index of suspicion high. So if you have increased left wall thickness, left ventricular wall thickness with any two of the above, then we should be starting screening. We're looking at heart failure above the age of 65, aortic stenosis above age of 65, a patient that has hypertension and all of a sudden he could not tolerate his hypertensive medication, a patient that has autonomic systolic nervous system dysfunction, peripheral polyneuropathy, a patient with unexplained late gadolinium enhancement, a patient with ruptured biceps tendon and bilateral carpal tunnel syndrome. So if you look and divide these red flags that we used to call them, then there are some clinical red flags and there are some imaging red flags. This is something that I encourage everybody who wants to get into the diagnosis of amyloidosis to keep in his smartphone or a smart device and keep on reminding ourselves with these in order to screen for the patient. So which test should we consider? We have at this stage a lot of tests. If you have high suspicion, then probably echo and MRI your best choice. If you have early diagnosis, then MRI and bone tracer scintigraphy is your choice, particularly if you're looking for ATTR amyloidosis. If you want a definite diagnosis for ATTR amyloidosis without resorting to biopsy, then we should use nuclear scintigraphy. If you want to look at etiologic diagnosis, then most of the data is now in BNB with very, very few data in bone marrow scintigraphy. So this is the cascade of amyloidosis. As you can see, probably sometimes you will only look at clinical finding, but as we go in the higher level of cascade of cardiac involvement, then where the nuclear scan comes in, and probably cardiac troponin and diastolic dysfunction. So the lower part, we have to have a high index of suspicion, and we should be probably looking actively for those patients, probably before we have the very end stage D heart failure with high mortality and morbidity. So this is the diagnostic algorithm that is accepted by many society. First of all, if you have a patient with signs and symptoms, ECG and echo finding of cardiac amyloidosis, do both of things simultaneously. Do do nuclear scintigraphy with bone avid tracer, and do hematological testing to rule out AL amyloidosis. If you have a scintigraphy imaging of grade 0 with negative hematologic testing, then probably neither of the cardiac amyloidosis is likely, and we should carry on with cardiac MRI screening and probably biopsy if your suspicion is high. If you have scintigraphy, which is a grade 1 and 3, if it is grade 2 and 3, then this is probably ATTR amyloid and need to confirm it further with cardiac. This is 100% cardiac ATTR amyloidosis, and you need to do genetic testing to see whether this is a wild type or hereditary type. If it is grade 1, then maybe you need finding a histological diagnosis either with endomyocardial biopsy or extra cardiac biopsy. If it is a grade 0 and positive hematologic screening, then obviously this is your AL amyloidosis. And if it is scintigraphy grade 1 to 3 with positive hematological diagnosis, then you would probably need to have a histological confirmation with invasive endomyocardial biopsy. So conclusion, ladies and gentlemen, a high index of suspicion is needed for the diagnosis of cardiac amyloidosis. PYP scan is probably the most important diagnostic modality in the diagnosis of ATTR amyloidosis. Negative PYP scan does not rule out AL nor ATTR. The diagnosis and follow-up of patient of cardiac amyloidosis definitely need a multi-modality imaging approach, looking at scintigraphy to confirm the diagnosis, echo and CMR for screening of testing. And I would like to finish with this paper, this graph from the JACC Oncology, Cardio Oncology, which showed probably that when we look at cardiac amyloidosis, we're looking at similar stages of any type of heart failure, in which there is a stage A before the presence of the disease, in which there is a neuropathy, a carpal tunnel syndrome, spinal stenosis, and a stage B where the valve disease, conduction abnormality, and atrial fibrillation happen before we get to stage C. And hopefully we can detect patient in these stages before we reach a stage D, in which we know that cardiac amyloidosis stage D heart failure is a fatal disease with high morbidity and mortality. With that, I thank you for your attention.
Thank you, Dr. Ahmed. It was very nice, and also you staged the diagnosis from 1A to D, which is very good, excellent. And we'll leave the question to the end. Please cast your questions in the chat box. And now from diagnosis to management, and we have talk about advances in the management of TTR cardiac amyloidosis. And this will be given by our dear colleague, Dr. Ammar Choudhury, Consultant Advanced Heart Failure and Echocardiography, King Faisal Specialist Hospital and Research Center in Jeddah. The screen is yours, Dr. Ammar.
Thank you very much, Dr. Faiz, for the kind introduction. And I would like to thank the audience for joining us late in the evening, the Saudi Heart Association for organizing this event. You heard a great presentation by Dr. Ahmed Jaziri discussing the evolving epidemiology, our explosive growth in our understanding of the disease, the different diagnostic techniques. But all of this, was possible because we have a treatment for both types of amyloidosis, AL and ATTR. And our focus in this session is going to be on ATTR. So, cardiac amyloidosis, particularly ATTR, has now moved from being an academic curiosity to something that you can actually treat, and the clinical implications are very important. And basically, our approach to the treatment, falls under two broad categories. One is disease-modifying therapies, and the other is general measures of how we manage issues related to heart failure. So we'll start here by talking about the disease-modifying therapies. At the moment, we have two approaches that are currently approved for managing ATTR. One approach relies on stabilizing the tetramer, the molecule that is produced by the liver, the transporter of the TTR stands for transporter of thyroxine and retinols, or previously known as prealbumin. This strategy is basically widely used currently. And the other strategy is to inhibit the production of this protein at the cellular level, at the level of the hepatocytes. So this idea about stabilization actually started, back in 1990s when a cohort of Portuguese patients was identified with the V30M variant. The V30M variant is also known as the Portuguese variant. It is characterized by development of polyneuropathy. It can be quite aggressive. But this particular cohort of patients did not develop the classic manifestations of this disease. Or even if they developed the phenotype, it was very mild. And the reason was that they had another variant, the T119M variant, which basically conferred protective effects. It stabilized the molecule. It strengthened the links between the tetramer, and it countered the destabilizing effects of V30M. This is what is known as compound heterozygotes. So this discovery was basically, utilized by a group of scientists led by Jeff Kelly at the Scripps Institute in California. So what their lab did is that they tested multiple candidate molecules to see which ones can bind to the thyroxine site and stabilize the molecule. And they discovered two molecules, diflunisal and tafamidis. Diflunisal is a very old non-steroidal anti-inflammatory drug. It was developed by Merck in the 1970s. It's relatively inexpensive NSAID, but because it is an NSAID, it was not clinically developed or repurposed for the treatment of ATTR, since ATTR is associated with heart failure. But the other molecules was developed, and later on it was called tafamidis. Pfizer got involved later on, and that led to the ATTRACT trial. So ATTRACT trial was the first of 3 large RCTs in the amyloid space that have been published and have led to approval of therapies for the management of ATTR. So tafamidis, its design and its findings are reflective of the era in which it was conducted. So this is a trial that was designed in the early 2010s. It was relatively modest-sized trial. It enrolled 441 patients. It wasn't powered enough for the individual outcome of mortality. So investigators did what is known as a hierarchical analysis or a pairwise comparison to calculate a win ratio. So they prioritize these endpoints, and they basically take a random participant from the placebo arm, and they compare them with a random participant for the treatment arm, and they look at mortality. If a mortality happens in the placebo arm, it's considered a win for the treatment arm. And if both participants remain alive for the duration of follow-up, they look at the second outcome of cardiovascular hospitalization and so on to calculate the win ratio. The inclusion criteria, importantly, of this trial were a wall thickness of more than 12. And as you saw in Dr. Ahmed's slides, this is one of the criteria that are used in clinical guidelines as well. So you needed to have, some degree of LVH to get into the screening process. They needed to have established heart failure, stage C, and they needed to have biopsy-proven ATTR. The reason being that this was prior to 2016, when bone scintigraphy was not yet established as a means for diagnosis of ATTR. So if you look at the baseline characteristics of these patients, they were old patients, right? So the average age was 74. This is older than what we typically see in HFpEF trials, where the mean age is in the high 60s. But as we are going to see later on, this cohort of patients were younger in comparison to the more contemporary trials, because a significant proportion of patients that were enrolled in ATTRACT had variant ATTR. The vast majority of participants were men, 90%. Only 10% were women. Now, this goes to the epidemiology of this disease. Many people would assume that, ATTR, particularly wild-type ATTR, is a disease of male, but there's more to the story, and that is most likely because the wall thickness criterion in the trial was not gender-specific. Women were underrepresented. And we know that from recent data from studies which use active ascertainment, where investigators try to find ATTR in vulnerable populations, that the proportion of women with wild-type ATTR can be as high as 40%. And as I discussed earlier, there was a higher representation of variant ATTR, around 24%. This is much higher comparison to the more contemporary trials, and that likely reflected the younger overall mean age in comparison to the more contemporary trials. NYHA function class 2 was around 60%. Most heart failure trials, NYHA 2 is around 70%. And the NT-proBNP value on average was around 3,000. And to put that into context, clinical trials that were done for ambulatory patients with heart failure and reduced ejection fraction, the average NT-proBNP is 2,000. For HFpEF trials, it's typically around 900 to 1,000. For obesity phenotype HFpEF, it's around 200. So this is a very high-risk cohort. So what were the findings? The win ratio was 1.7 in favor of tafamidis. For the individual endpoint of mortality, we're talking about all-cause mortality. We're not talking about cardiovascular mortality. We're not talking about heart failure hospitalization. We're talking about an endpoint that is really the most hard clinical endpoint, mortality. In the placebo arm, the survival was 57%. So the flip of that mortality was 43%. And survival with tafamidis was 70%. The flip of that mortality was 30%. So that represents a 13% absolute risk reduction, number needed to treat of 7.5 over a duration of 30 months, which is 2.5 years, and a relative risk reduction of 30% in all-cause mortality. This is extremely impressive, and you can see that this effect starts after a year and a half, after 18 months. When you look at the individual secondary endpoints of 6-minute walk distance, or the KCCQ, which stands for Kansas City Cardiomyopathy Questionnaire, which is a survey that assesses the quality of life, we can see the significant difference between placebo and treatment. It was a whopping 76-meter difference in 6-minute walk distance, 13.6-point difference in KCCQ. Anything above 5 points is considered clinically very relevant. Do note, however, that even with the treatment arm, there was a decline. So the treatment, what it did, is that it did significantly, in relative terms, improve the outlook compared to placebo, but it did not necessarily improve the status of these patients compared to their baseline. So that's an important thing to keep in mind. Also note that attenuation in progression is reflected in cardiac structure and function in terms of EF, filling pressures, GLS. You can see that there is progression, deterioration with the treatment with tafamidis, but it was less pronounced compared to placebo. Now, when patients enter the open label phase of the trial after the 30 months, the vast majority elected to switch from placebo to tafamidis. Their outcomes did improve compared to their expected mortality in the placebo, but they did not catch up with the arm that started on tafamidis from the get-go 2.5 years earlier. And this again tells us how important it is to make the diagnosis early, because the outcomes of the patients will depend on that. You can also see over here some heterogeneity in the outcomes according to the baseline NYHA functional class. So NYHA functional class 3 patients did not do as good as NYHA functional class 1 or 2. So this led to the approval of tafamidis by the FDA, US FDA. It was approved in Saudi Arabia as well, and it is a relatively accessible agent, although it is still quite expensive. Another therapy in this space is acoramidis. You can think about it as a second-generation kinetic stabilizer, and it was developed to truly mimic the effect of the T119M variant, and it results in greater stabilization of the TTR tetramer. So this was tested in the ATTRibute cardiomyopathy or ATTRibute CM trial. It was slightly larger than ATTRACT. It had, similar design elements, similar sort of pairwise comparison was done to calculate a win ratio. The most important key difference is that patients were allowed to enroll on the basis of nuclear scintigraphy. So biopsy was not required, was not a prerequisite to get into the trial. So obviously this opens the door for earlier diagnosis. It opens the door for people, elderly patients that might be hesitant to undergo biopsies to be enrolled as well. There were some exclusion criteria. These investigators learned from the ATTRACT experience with tafamidis, the heterogeneity in the outcomes, especially with advanced heart failure patients. So they excluded patients who had very low GFR or those that had an NT-proBNP of more than 8,500. The follow-up duration, again, was 30 months, very similar to ATTRACT. So here you can see that because of the inclusion of more patients with wild type, the average age was more. Now it was 77 years compared to 74. Female representation was the same. Variant ATTR now accounted for a smaller size of the pie. There were, 24% with ATTRACT, is tafamidis. Now it was around 10%. And you can see that there was a higher representation of NYHA functional class 2 compared to ATTRACT, and the average proBNP was also slightly less. So again, it was a win in favor of acoramidis, and in terms of all-cause mortality, there was a reduction in all-cause mortality of around 23% in relative terms. It did not reach statistical significance, but if we look at the Kaplan-Meier mortality curves, the placebo arm mortality at 30 months was 26% compared to 43% with ATTRACT. And with acoramidis, it was 19% compared to 30% mortality in ATTRACT with tafamidis. So this is basically a reflection of the fact that this is a different cohort. This cohort has a milder form of disease, but the therapy is equally effective. You see the separation of curve again happening after 1.5 years. With acoramidis, however, there was more granularity to the data in terms of structural and functional effects of the therapy. So a subset of patients, relatively small, less than 30 patients, underwent cardiac MRI analysis at various point times. And what these scatter plots here show is that there was attenuation as well in terms of LV mass index, in terms of improvement in volumes, in ejection fraction, but there were patients that experienced regression. There were patients, some of them did have progression, less so compared to placebo in terms of LV mass, but there were patients that had regression in LV mass. There were patients that had, progression in ejection fraction, but there are also patients who had improvements in ejection fraction. And the same applied to GLS. Here's an example at the bottom of one single patient whose ECV on cardiac MRI did actually, get less with acoramidis. So this was, basically data to suggest that there is heterogeneity in response. There will be some patients that may experience reversal, disease regression, because of the intrinsic ability of the body to clear up amyloidosis. And those are probably likely those patients that are diagnosed relatively early. So what about the other strategies? What about the strategy of inhibiting the production of TTR? Now, there are two ways to do that. One is by using small interfering RNA molecules, and the other one is using antisense oligonucleotide. So in essence, sorry, this is my, just gonna go back to my slides. Okay. Yeah, okay. Sorry about that. So with small interfering RNA, this is basically a double-stranded RNA that enters the cell, hepatocytes, and then it combines with a molecule called arginate to form the RNA-induced silencing complex. So the lead strand will stay, and the passenger strand of the RNA will be lost. And this RISC molecule will then find the mature messenger RNA in the cytoplasm. It will bind in a complementary fashion before the mRNA reaches the ribosome. So it will break it down and it will prevent the production of the protein. With antisense oligonucleotides, on the other hand, it's a single-strand RNA or DNA. It will bind to its target and it will cleave it potentially in the cytoplasm or even inside the nucleus. So the first molecule that was developed was actually a small interfering RNA called patisiran. It was tested in patients with variant ATTR who had polyneuropathy. And what it showed is that it was able to not only, stabilize the disease or attenuate the progression of the disease, but it actually improved neuropathy scores on average. So patients with polyneuropathy experienced improvement in their symptoms with this agent. Now, half of these patients had cardiomyopathy as well, and they experienced regression of some of their parameters, cardiac parameters, like relative wall thickness. The LV mass basically improved. So this was a proof of concept study in terms of cardiomyopathy. And investigators then went on to test this agent in patients with cardiomyopathy exclusively with heart failure. The follow-up here was too short. It was only 1 year. The primary endpoint was only 6-minute walk distance. And even though there were statistical improvement in terms of 6-minute walk distance, in terms of the KCCQ score, the numbers were very small numerically, and therefore it did not, undergo approval by the FDA. But the same pharmaceutical company developed another agent called vutrisiran. This can be given by a healthcare provider in the hospital as an injection every 3 months. Again, this was larger than the ATTR-ACT trial, and it was powered for the conventional endpoint of mortality and total cardiovascular events. The inclusion and exclusion criteria were quite similar to the acoramidis trial. They did not have an upper cutoff for NT-proBNP, but they did exclude patients with NYHA functional class 4 heart failure, and also with National Amyloid Center stage 3, which are basically patients with an NT-proBNP more than 3,000, GFR less than 45. What was unique about the trial is that because it was relatively recent, many of these patients, 40% at baseline, were already taking tafamidis, and 20% started tafamidis during the trial. So they were basically labeled as drop-ins. And the baseline characteristics were quite similar to the acoramidis trial. Similar age group, similar representation of women. Variant ATTR was around 12%, and the vast majority were NYHA functional class 2, but the proBNP was even lower. So in terms of that composite endpoint, there was close to a 30% relative risk reduction with vutrisiran versus placebo in the overall cohort. And in the patients that were receiving vutrisiran alone, it was around the same number, close to 34%. Now, with respect to the individual endpoint of mortality at 42 months, now the duration of follow-up is longer. It's not 30 months as it was in ATTR-ACT or with attribute. It was a bit longer. You can see that there was a 35% reduction in all-cause mortality in the overall population. And in the monotherapy arm, it was again close to 35%. So, excuse me. So here what we can conclude, one is that with the overall cohort that included tafamidis, the hazard ratio is similar to the monotherapy arm, which means that tafamidis is not attenuating the efficacy of vutrisiran. Looking at the raw numbers, we see that in the overall cohort that included tafamidis, both the treatment and the placebo mortality is actually lower compared to the monotherapy arm, which tells you that there potentially could be an additive effect of background therapy with tafamidis. Again, this is very hypothesis generating. There was no randomization when it came to tafamidis in both arms. But these are sort of early exploratory findings that would be worthwhile to confirm in future with ongoing trials. If we look at the effect on worsening heart failure, we can see that the effect starts much earlier. All-cause mortality, the effect is seen after a year and a half, after 18 months. But in terms of worsening heart failure, the effect is seen much earlier, as soon as 3 months. And here again, overall, looking at the entire population of 655 patients, the use of vutrisiran was associated with attenuation in the progression of disease in terms of cardiac structure and function, except for diastology parameters. The diastology parameters were clearly improved with vutrisiran. But with when data was kind of analyzed on the basis of cardiac MRI in a small cohort of patients, around 22 patients who underwent cardiac MRI at time of entry into the trial at 24 months and even at 36 months, there were clear indications that there were patients who would derive a greater benefit, who would actually see regression of the disease, who would actually see not only attenuation in progression in ejection fraction and LV mass, but they would actually experience improvements in ejection fraction and clear significant reduction in LV mass and reduction in extracellular volume. So here, if we plot the outcomes for all of these studies, we can see that at the 30-month mark, the relative risk reduction with vutrisiran in HELIOS-B, with acoramidis and ATTRibute, with tafamidis and ATTR, the relative risk reduction is quite similar, okay? But the mortality overall for these patients has changed. Back at the time of ATTRACT, with the placebo arm, the mortality was very high, okay? And now we are seeing with vutrisiran, plus or minus tafamidis, the survival is up, or mortality is approaching that of age expected mortality. So we have made tremendous strides in the management of this otherwise fatal disease. So eplontersen is currently under investigation, and the results will be out from CardioTransform later in this year. What about permanently corrupting the genome using CRISPR technology? So CRISPR can allow the introduction of frame shift mutations that will permanently inhibit the production of ATTR after a single infusion of this agent, leading to close to a 90% inhibition in the production of TTR. So this has been shown to be a promising therapy, and it is the subject of an ongoing phase 3 clinical trial where the results will be announced in 2028. What about amyloid depletion? So amyloid depletion can happen, as you showed through data with acoramidis and vutrisiran, that some degree of regression may happen, particularly early in the disease. There are some case reports of patients who spontaneously cleared their amyloid, plausibly because they developed some antibodies. And this has been shown with specific therapies, antibodies to ATTR that can trigger macrophages that can actually clear the disease. And this would be the holy grail of ATTR management using these agents that could actually reverse the disease. So these are the ongoing questions: kinetic stabilizers versus gene silencers. Bottom line is there's no head-to-head comparison because kinetic stabilizers were never shown to be very effective in polyneuropathy. If you have a patient with polyneuropathy alone or a mixed phenotype, you should probably use gene silencer. We still don't know how well to predict response to therapy. Maybe measuring TTR values in patients on kinetic stabilizers might prove to be a way to see if the patient is responding to therapy or not. Kinetic stabilizer plus gene silencers, early indications from HELIOS-B, maybe it is effective. We'll probably have more data on this particular question from CardioTransform. CRISPR technology, the phase 3 trial is called Magnitude, that will be completed in 2028. Depletion trial is also ongoing, a phase 3 trial. What about pre-symptomatic, stage A or stage B? Act early will answer that question. What about the elderly above the age of 80? There is data to suggest they derive equal benefit. What about conventional therapies? Some questions are unanswered. Anticoagulation should be used if there is AFib regardless of CHA2DS2-VASc. But what about sinus rhythm? Should we anticoagulate some of those patients? What's the role of ICD? What about GDMT? We use diuretic therapy. We can use midodrine for hypotension. We should avoid negative inotropes like calcium channel blockers and digoxin. We should not be using ACE or ARBs because they have not been shown to impact outcomes in propensity matched analysis. Beta blockers might be beneficial if the EF is less than 40, but should be cautiously used. MRAs and SGLT2 inhibitors probably are the most promising. So this is the summary of what I mentioned in terms of treatment. If the patient is too late, NAC stage 3, NT-proBNP more than 8,500, maybe palliative care, maybe transplantation if they are a candidate. If they are way too early, stage A, stage B, maybe just monitor them, surveil them. Stage C, you should treat them, NYHA function class 1 to 3, polyneuropathy, mixed phenotype, gene silencer. Otherwise, you can use any of the 3 agents that are accessible. To conclude, prioritize cardiac amyloidosis in your differential diagnosis of HFpEF. Do make sure to differentiate between AL and ATTR. Cost and timely access to therapies are formidable challenges. Await long-term data on next-generation therapies and combination therapies. And with that, I will conclude, and I would like to thank you for your attention.
Thank you. It was very nice talk and very nice wrap up of the management of the amyloidosis. Okay, so while we are waiting for some questions, so we'll just start by asking Dr. Al-Jaziri. You know, in spite of the awareness and availability of non-invasive testing for the amyloidosis, still there is, what do you think, what are the barriers of delaying the diagnosis and rarity of the cases?
I would like first to thank Dr. Ammar for the comprehensive overview. I learned a lot over the past 25 minutes. Well, I think the challenges is twofold. The first fold is the non-specific presentation. So even when people still think of amyloidosis, they always think, okay, I should probably rule out uremic cardiomyopathy. I should be probably rule out hypertensive cardiomyopathy before I start looking for amyloidosis. And the second step is actually there is a bit of a learning curve in the reading of nuclear scan. Before the implementation of SPECT-CT, there are a lot of overlap because patients were called positive, not because they are truly positive, but because of the blood pool increased signal that is related to heart failure rather than to the muscle. So these are the two barriers. The fact that we usually still think of other diseases other than amyloidosis. And then there is a bit of a learning curve with comfort zone around the diagnosis of amyloidosis based on imaging, since there is a lot of uncertainty sometimes in the way we interpret the images.
Do you think physician inertia is one factor also, or no? That's why we are doing these webinars every now and then.
I totally agree, and I'd like to again to thank the Saudi Heart Association for putting these webinars. I can say that since these or the talk about amyloidosis significantly being in the media, there is an increase in the referral, at least to our imaging center, regarding possible of cardiac amyloidosis. And well, fortunately or unfortunately, I cannot say, most of these tend up to be AL, but the fact that we kind of broken the inertia is a great step forward.
Yeah, and also, you know, this patient passing by multiple clinics, you know, multiple subspecialties, and he's rotating on these clinics, and I think this is difficulties, and this is delaying the diagnosis. It takes a year or and more to diagnose this patient, right?
I totally agree.
Okay. Dr. Ammar, excellent management and excellent treatment. So what do you think the near future, the combination therapy between the stabilizer and silencer, and this, do you think it will come soon, or it takes time to come to reality?
Yeah, yeah. Currently, in the algorithm that I shared with you from the ACC task force, they are not advocating to combine therapies. It's extremely expensive. We didn't, talk about that because of shortage of time. But we are looking at the cost of, $250,000 reals per year. And so if you're looking at, combination therapy, it will be cost prohibitive. So that is one of the bigger barriers. The other thing is that we really don't have the data. And CardioTransform will have multiple arms. It's the largest trial in the amyloid space, 1,400 patients. Results will be announced at the ESC in August. It may many people say that it may help answer some of these ambiguities. But like you mentioned, like Dr. Ahmed mentioned, the barrier of diagnosis is significant to start with. Access to therapy, I think, within our system is improving. Um, you know, as the patents are lost, maybe there will be generics down the road. There will be more competition. Hopefully the landscape will look more promising, inshallah.
Very good. So about genetic testing, where we send this patient to do genetic testing? Should we send them to a specific hospital? Like I know so King Faisal, they have it, or the companies like New Bridge is doing this genetic testing, or what is the management to do this genetic testing?
Yeah, I think for healthcare providers that are managing this disease, they have various, access to multiple resources. They can certainly enlist the help of the pharmaceutical industry to guide them. But there are regional labs with expertise to do a whole exome sequencing in multiple geographic areas, and it's important to do this in collaboration with a genetic counselor because there are some ethical questions that do come up. For the index case, it may not matter much, but to screen their relatives, their children, their siblings, knowing the disease, what implications it may have in terms of monitoring, in terms of treatment, what are the societal implications. So it should probably be done in conjunction with a genetic counselor.
Excellent. Do you think we need to have a cardiac amyloidosis clinic, and who should run this clinic if you agree to have this clinic, such a clinic?
Yeah, I mean, certainly having more specialized clinics is great. So if your service already is providing specialized valve clinics, heart failure clinics, and so on, maybe yes, adding these cardiomyopathy clinics would be very much advisable, where you can see all these patients that have LVH, not only amyloid, but also hypertrophic cardiomyopathy. Some of these patients tend to have rarer conditions, Fabry's disease, for example, AL amyloid, and so on. So lumping them together would be a good idea. But if you don't have the infrastructure for the basic services, you don't have yet a heart failure clinic or a valve clinic, probably those would take the priority. Maybe those are the ones that, develop the infrastructure, get those started first, and then work on these more hyper-specialized clinics. But I think, going back to the screening process, we should probably be more attentive to the issue of wall thickness increase. We often see that embedded in the echo report somewhere. People don't pay attention, or they may have comorbidities like hypertension and so on. So they just dismiss that. They don't actually look at the numbers. And then the issue that I also raised, and Dr. Ahmed Jaziri as well raised, there's an ongoing registry, a prospective registry called Maestro, that announced some of their preliminary findings at the HFA meeting in Barcelona just a couple of weeks ago. And only 52% of women basically had a wall thickness average of more than 12 millimeters. So roughly half of women may have a wall thickness of less than 12, which is the classic threshold that is being used even in the guidelines. So I think there's a lot of work that needs to be done about early. And okay, if you screen these patients, how good is your testing? You mentioned that as well, the issue of blood pool contamination, these false positives. There's a paper from the Mayo Clinic looking at the utility of nuclear scintigraphy, 1 hour versus 3 hour. In that study, 114 participants, there were 2 teams analyzing nuclear scans, SPECT scans, and the third team, which was being used for arbitration. Out of the 114, 30 patients required arbitration by the third team. So there was disagreement at the Mayo Clinic between 2 expert teams about calling this grade 1 or grade 2. So there's a lot of work to be done. Maybe with PET scans and better tracers, this can be addressed, but a lot of work that needs to be done.
Dr. Ahmed, you have the clinic in the National Guard, or?
We are still building it up. The problem is as Dr. Shoideri said, is the logistics. Having a cardiologist running the clinic alone may not be the optimal thing. You need probably a cardiologist, a nephrologist, and a neurologist in parallel in order to come up, and a hematologist. Then you have to have probably a coordinator, because if this patient comes to you today and the next scan, nuclear scan, is in 6 months, you already have lost a lot. We are still running some of the logistics, but what we started is making an open access for imaging. So we probably get the patient within the week he was referred to us to get his MRI and nuclear scan and an echocardiogram. But we're still having some difficulty aligning all the specialty in one line.
Yeah, that's why I
That's
suggest
tough.
this clinic will the patient seen in the clinic and the consultant is rotating, the specialty is rotating, like gastro this week, gastro next week, hematology next week, cardiology next week, nephrology. So this patient will not fragment him, but will see him by different specialty in the same clinic and same coordinator. Maybe it works like this, but later on we have to have to transform it from rare disease to just reasonable cases. Yeah, I think it is underdiagnosed.
Absolutely.
We have patients who did aortic valve replacement, mitral valve replacement, and heart failure, and at the end, before his mortality, we discovered that he's amyloidosis. He did it in multiple hospitals. He did one operation in National Guard, the other in military hospital, the other in there. And at the end, we discovered that this, because now we have the management, that's why we diagnose these patients. Excellent. We have a question here from Dr. Shamsan, Halim Shamsan. How frequent we are doing cardiac biopsy? Sometimes the CMR and BYB scan doesn't give a conclusive result. How frequent we are doing this cardiac biopsy in both institutions? We need to listen about you, National Guard and King Faisal.
So a National Guard, out of the referral that we got, we end up doing biopsy in 2 patients in whom we were highly suspecting amyloidosis, and all the exams and tests were negative and they come up as amyloidosis. So 2, I think, out of like 60 or 70 referral, we had to get the biopsy to get to the diagnosis. So it's not that frequent.
Yeah, I think I echo that. At our institution, in the beginning, we were doing a couple of, fair number of biopsies actually, because at the time, planar imaging was being used and then SPECT was added. Since the utility of SPECT CT, hybrid, fusion imaging, I don't think we have biopsied anyone. In the referral centers, like the National Amyloid Center in the UK, I think the numbers are around less than 10%.
Okay. So, Dr. Ahmed, you mentioned BYB1. What to do? You just reiterate this again.
If you mean BYB as grade 1?
Grade 1.
So the grade 1 is not the highest. The higher the grade, the more likely that you have ATTR amyloidosis. The lower the grade, it could be non-specific, or the patient has early ATTR amyloidosis, or the patient has AL amyloidosis. This is when you probably resort to cardiac MRI and echocardiography in order to see whether there is a high suspicious. And if you still highly suspecting amyloidosis, then probably knowing that if you miss AL involvement in the of the heart, you may lose the patient fast. I usually resort to biopsy in this case, faster than I would like to do so.
Excellent. Do you think that cardiac MRI will replace the echo or come with the echo in the early stage in the algorithm itself? Because the cardiac MRI is not in the algorithm except if very late if we need it. This, because this is a cardiac MRI is a super echo.
Yeah.
Okay, it is a super echo, and if it is coming early, we can say echo / cardiac MRI at the beginning. It might give a help to diagnose.
I think echo would always be the first. Mobility, accessibility, time-wise, in the time that you do an MRI, you can easily do 3 echocardiograms and come up with final diagnosis. Now, the more and more, of course, the more and more we have wide availability, improving the sequence in terms of sequence and protocoling of the sequence that do in MRI, we will probably do a better job in detecting. But I think echo will always be there. It will be probably the first choice to go to, knowing that it can be fast, mobile, and accessible. And MRI will definitely remain one of the pillar of the diagnosis, particularly in terms of the function, tissue characterization. But I think the new kid in the block is the PET tracers. The PET tracers has the higher sensitivity, higher specificity, ability to quantify. And once we are able to quantify, we will be able to follow up these patients in order to see the improvement of the amyloidosis.
Do you do it in your center? Because it is not available everywhere.
Unfortunately, all the PET tracers are phase 3 trials. They are not FDA approved. I believe that before the end of the year, we will have the first tracer from Bayer, because they have already announced in May that they met their specificity and sensitivity criteria or endpoint. So most of these goes into breakthrough, fast FDA approval, and we will get them in the market. This is only one part of the equation. The second part of the equation, of course, is the availability of the PET scan. But since it is done at rest, fast image acquisition, and the higher ability to diagnose cases, because there are a lot of case reports and in phase 2 trials where when they did a BYB scan and it was very faint or barely there, the PET tracer were very avid, which means that we are looking in a much higher specificity and affinity to the tracer. So sooner it will be similar to doing an FDG for staging of cancer, and it will take a big chunk of the diagnosis from BYP scan.
Thank you. I think there is no more questions. And before we end this excellent session, we learn a lot from both of you. And I need just 1 minute from each of you about your advice and conclusion in your talk, please.
So I will start, since I will be the diagnostic part. Keep a very high index of suspicion. Think of amyloidosis at any time that you come across something that is very strange or very, very common but cannot be explained by the common diseases. Don't stop at the usual diagnostic patterns or diagnostic test if your suspicion is high.
Thank you. Dr. Ammar?
Yeah, my advice is also actually pertains to diagnosis, because we have encountered several patients now with AL amyloidosis that were being treated with tafamidis. So these were patients that had very aggressive, clinical presentation. Their PYP scans were strongly positive, grade 2, grade 3 uptake, and they were, presumed to have ATTR. This is a very major pitfall. Dr. Ahmed, highlighted that several times in his slides. I think the pendulum has swung so much towards ATTR, because we were talking about ATTR, that people do forget about AL. They don't remember the diagnostic tests, what to order. So they lost a very valuable very valuable time, a couple of months on tafamidis, getting worse and worse, and they were referred too late for AL. So unfortunately, this is still a major problem that is preventable. And I think, our educational efforts should try to address that as much as possible.
I have one patient also, a very high index of suspicious. If you look at her cone eye, bone tumor, everything, she looks like AL amyloidosis. And we referred to hematologist, and he said this is AL amyloidosis, and unfortunately all her labs are negative. But they came again, and they will repeat the test again because the patient is highly suspicious. That's why if you suspect clinically, you have to just work it up until you diagnose. rightly, not falsely. Okay. I would like to thank the Saudi Heart Association and the Saudi Heart Failure Group and the Dr. Ibrahim Jaidan and the team. And I would like to thank this excellent speakers, Dr. Ahmed Al-Jaziri and Dr. Ammar Chaudhary. And I would like to thank the audience also for their attendance. We have a very good number of audience. We have about 245 audience today. And we had to thank all of you for that excellent meeting, and see you soon in another webinar. Thank you.
Thank you so much. Have a nice evening.
شكرا. السلام عليكم.